they get in the various parts of the body, precisely the joints. But a bigger complication that happens is the stroke, or when the occlusion occurs in the brain. So we all know that the brain is a very vital organ in the body that plays several roles in posture, in memory, in your ability to learn, in vision, in speech, and balancing and all that. So you agree with me that once there's an occlusion to any part of this vital organ, then it's going to result in several impairments. In part where there's a partial or a total impairment in the function of that part. So just for other people who have joined on to be able to identify with I don't want to go more into the pathophysiology, but then a stroke is simply a sudden interruption to the blood supply to the brain. Now, so we are all very familiar with these two pictures where you have the upper part of the picture where the red blood cells are flowing through the vessels easily. And then the second picture where there's the occlusion. So this same occlusion also occurs in the brain. Now, we initially thought that it was these occlusions that were causing the strokes. But recent research have shown that it's actually the larger arteries going to the brain that are the primary causes of strokes in patients with sickle cell disease. How does that happen? So as these rigid red blood cells that we've spoken about just briefly, they tend to clump. And as they clump, they get attached to the larger, the walls of the larger arteries, and then they damage the vessels. And as this happens, then there's narrowing in the vessels. And so what we also want to bear in mind that it is just not the small vessels, but also the damage that happens in the larger vessels due to the clamping and then the attachment of the red blood cells to the inner aspects of the vessels.
Thank you so much, Ms. Dinah. So now we know what sickle cell disease is, and we know that we know what stroke is right now. And now we understand that it's actually the larger vessels in the brain. So the internal carotid artery and the middle cerebral artery, they are the Would like to apologize to you all for the network hitches. We'll just continue with the discussions. So this program, once again, was brought to you by Pediatric Society of Ghana and then Novartis. So Nana was speaking about his experience. So the last question was his reaction when he was told his child had stroke.
Well, as I said earlier on, it was a little bit, hard for the whole family, especially my wife. But as a man, you cannot just be showing emotion anytime. So you have to be the backup of the family. And as a man, you have to be the backup of the family and stand strong for anything that comes. So that is it. It was only my wife that was a little bit down, but me, I was okay.
All right. All right. Thank you so much, Nana. So I'll come back to you. But what we learned from Nana this afternoon is that in any child with sickle cell disease, don't assume that every pain is vaso-occlusive crisis, because it can also, let's think stroke as well. So I'd like to speak with Ms. Dinah again. Can you tell us how common is stroke? And then what are some of the ways that children with stroke can present clinically?
So if you compare an average child to an average healthy child to their age mate who has sickle cell disease, the child who has sickle cell disease has as much as 250 times risk of having a stroke if you compare to the average age. Now, it's also estimated that patients who have phenotypes HBSS and S-beta thal 0 have an increased risk of developing stroke. Again, if you have a patient who has sickle cell disease and they are running very low hemoglobin levels, so sometimes we hear a lot of parents, and even we as healthcare professionals, we keep saying, oh, the child is fine. They don't have any pain. The child is fine. And so we sometimes don't want to look elsewhere. But that child that is running those low hemoglobins is actually at risk of developing a stroke, even though they may not be coming in with vaso-occlusive painful episodes. By virtue of them running very low hemoglobins, they put them at risk. It puts them at risk of developing a stroke. Again, there's a familiar predisposition to somebody having what? A stroke. So if you have a sibling or an older person or somebody in the family having a stroke, then this can also put the person with sickle cell to also having a stroke. Also in patients who have complications such as acute chest syndrome. Now it's estimated that if you don't put any stroke preventive measures in place, 11% of all patients with sickle cell disease will have a clinically overt stroke by the age of 20 years. And 1/4 of these patients will have a stroke by the time they are 45 years. Additionally, 20 to 35% of children with phenotypes HBSS will have a silent stroke. So these are strokes that don't have any overt signs. Approximately 10% of the children with HBSS will have what? An overt stroke. So up to 35% of the children will have silent strokes where there are no signs of the stroke, and 10% of them will have overt strokes. So the mean occurrence of these clinically evident strokes is from 7 to 8 years, but your highest risk of developing a stroke is between the ages of 2 to 5 years. So if you are a clinician attending to children with sickle cell disease, it should tell you that the crucial time between 2 to 5 years is an age group that you should actually have a close look at, because that is the time the child has an increased risk of developing a stroke. It's where you have either it is an ischemic stroke, which is normally what is very common in children, because today we are talking about children, where these strokes are often occurs in the children under the ages of 15, and then in adults by the age of 30. In hemorrhagic strokes, which are not common in children, yes, which are not common in children, you realize that these occur in younger adults. So if you are here either as a physician taking care of adults, then you should take note of this. And then in the children, pediatricians and those of us taking care of children with sickle cell, then we should take cognizance of this.
All right. Thank you so much, Ms. Dinah. But I would like to ask you, when it comes to the way children with stroke present, we all know that usually, I mean, everybody would know that when somebody has stroke, they can have weakness in their limbs and all that. But when it comes to children, apart from the weakness, are there other clinical features that health workers, clinicians, and even parents should look out for?
So I'll start from the silent stroke and zoom into the overt ones. So for the silent stroke, the dicey thing here is that there's no overt sign. So I'm sure people are wondering, so how do we find out if somebody has a silent stroke? One of the clues is that if the mother comes to you and complains as your part of your review of your patient in the clinic and tells you that my child's academic performance is declining, my child was doing well academically, that please have your ears should stand up and think about a silent stroke. That could be the beginning of it. And with that, the only way to find out is to do what? An imaging, but there will be no overt sign. Now with the overt signs, it's very dicey. I've had a lot of parents come to me and tell me that I just woke up this morning to prepare my child for school and she wouldn't get up. So I thought she was playing, but she tells me, Mommy, I cannot stand. And truly to when they pick the child to stand, that child cannot stand. Or the parents will tell you that they went and then the child was just staring. The eyes were just staring. Or they may come with seizures or even sudden loss of consciousness or severe headaches. I've had children come and play in the clinic. And then I get to the emergency room the following morning, and that child is there with a stroke. Or the child may come to clinic, and then there's nothing wrong. And the following day, that child is in the ER with a stroke. So you realize that the presentations are quite funny, that even you, the clinician, sometimes you are baffled. And that is why people tend to think, and just like Mr. Dankwa told us, the first thing that comes to us is that it's a VOC. It's a painful episode. But think about stroke. Why would a child that is not febrile have a convulsion? So don't think about these overt signs. So a child comes to you, suddenly there's a hemiplegia, there's weakness. Sometimes they become aphasic. Sometimes there's a facial deviation. Sometimes it's just inability to swallow. And I have a child, that was the presentation that the child came to. The mom just said, the child cannot swallow. And when they put a liquid into the child's mouth, everything, the child was choking to death. And then we have the TIs, where it's just a transient thing that passes. But if you have a smart parent, they will record the video for you. And I had a mother that had 3 episodes. He said the child is there, the face just changed, twitches to a part, and within a few seconds, it's back to normal. And if you are not seeing the videos of this mother, how do you, as a clinician, try to put together that this child could have what? A stroke. So yes, we are not looking for the overt signs where we are having the hemiplegias, but we should have at the back of our mind that these persistent headaches could not just be malaria headache. If in a child with sickle cell, please think about stroke, and not always think that the child has what? Has a painful a bone pain, or may have other things about it. So these are a few of the overt signs that we can see in it. So as parents, as clinicians, if you are seeing any of this, please don't take it on the face value. Seek help.
Thank you so much. So this is really enlightening. Let us remember that children are not always, they are malingering or pretending when they refuse to stand. Let's think through. But can you tell us some of if a child has stroke, can they have visual problems? Can it be a sign of stroke?
Yes, and then, so we all know the functions of the brain. So your sight is controlled by the brain. So depending on which parts of the brain the occlusion happens, then you may lose the function either partially or fully. So like I said, some of the children are aphasic. They are not talking. Some of them, after a few hours, it recovers. You realize that the child starts talking, even though the speech may be slurred. Some of them may recover and you may not see any signs of them. I also have a few of them who have been aphasic for long. I have a 3-year-old, and she walks into the clinic and she comes to give me a hug. And then there were medical students there, and I just asked her this, and she did this. The medical students were watching the child and were wondering why the child was not talking to me. And then when they went, and one of them asked, "Why is the child?" I said, "Yes, she does, but she lip reads, because this is not a child that was born, yes, but she's had a stroke at age 3, and that's why she's aphasic." So the same thing can happen to what I've had people being brought to the clinic from the ophthalmology because they went there with visual problems and they realized that the person has what? Sickle cell. And when they came, you realize that they may have a stroke that nobody picked up. And then what is actually bringing them in is rather the visual impairment. So us being able to also diagnose them is also very, very what? Key. So how? History. So your history taking is so important. If you are taking the history and you skew your mind to this could be bone pain, this could be this. And I'll share an experience with you. One of my patients, I had earlier this year, they referred 2 children from the Volta region to us. And the girl presented 2 years ago to a nearby facility with sudden weakness. And the first thing that came was being managed was to think about an acute flaccid paralysis. And the father told them they took several stool tests. People came to take samples from the child's mouth. And then eventually they said, oh, they were not too sure. And this child was discharged home. So the history, what history was taken from this patient? Ironically, this child was diagnosed with sickle cell in that same facility and then was lost to follow up. And then 3 years after that, the child presented to that facility with a sudden weakness. But nobody thought that that child could have what? Could have a stroke. What went into the examination of this child? Neurologically, what were they picking up? But this child had overt signs. But who could pick them? So your examination is equally as important as your history that you have taken. And what are you looking out for? The facial deviation, are there any decrease in the tone and all that? Very, very important. And then the child is not swallowing. So these are all signs that will come, or the child is having seizures in the absence of any temperatures. And for these seizures, I'll put in, we had a child who we managed for ACS, had temperatures settled. We discharged the child home. 48 hours after the discharge, I got to the emergency room in the morning. The child was there with seizures at dawn. So the mother woke up and the child had seizures. And then they brought him. The fever had subsided, but the boy had had a stroke. 2 days of leaving the hospital. So these are very important. What about imaging? So if you find yourself anywhere outside Accra, Kumasi, or even Tamale, how many of us have CT scans? That's the dilemma of a clinician. Do you want to see the CT scan before you say the child has a stroke, where the next CT scan is 6 hours from where you are? These are dilemmas that you cannot do away with. Talk about MRI and MRA. That is out of the reach of several people. So your history, your examination are very, very key. The CT scan, the MRI, the MRA are bonuses for you. So don't think more about CT. Look at the event. Even picking the stroke out is the key. That is the first key of it.
Thank you so much, Ms. Dinah. As we are learning from here, we know that we're able to pick up stroke in children and then forward them for appropriate management. But before I come back to you, I would like to speak to Jemima. We are now zooming into, now we know the symptoms and diagnose, and we are zooming into management. Can you tell us what physiotherapy is all about? And at what point in stroke should we let you come in?
Thank you very much. Okay, so physiotherapy is as also known as physical therapy. So our focus is to achieve the highest maximum function as much as possible for the client. The highest maximum function as much as possible for the client. So physiotherapists come in when a child has had a stroke. We don't wait till discharge. Even on the wards, we come in. So usually after the client has been admitted, if it's an inpatient client, and then medically is stable, they are referred for physiotherapy management. So on the wards, we start with our rehab. We don't wait till the client goes home. It's very important you start right from the beginning. After the client is medically stable, and it's good to start physiotherapy. You don't wait till they are out. You don't wait after months or 6 months, years. The first 6 months in stroke rehabilitation, we realize that there's a sharp increase in the curve. So at that point, right from the ward, you start your physiotherapy. As a clinician, you go there, you do your physical therapy assessment. So the assessment on the ward, you look out for the strength, the muscle strength. You look out for the functional assessment, what the client can do and then what the client cannot do. If the caregiver, the parent is around, you have to find out what they have lost before they had the injury, before the stroke happened. Then you take it from there, right from the ward. Sometimes there may be hemiplegia, hemiparesis, paraparesis. or monoparesis. So if there is plagia like this, you would have to start from the very basics. You have to start from the very basics. Then usually, before we even start our exercises, it's very important. You have to let the parents know that now your doctor has informed you that your child has had a stroke. You have to educate them on what physiotherapy is. Most of the times in our country right now, most people think physiotherapy is about massage. So even when you go to the wards and then you tell them you are coming for physiotherapy, they think, oh, into the massage, you know. But that is not what physiotherapy is about. We are here to do exercises with your child so that we can achieve the maximum function as much as possible.
Thank you so much, Jemima. I think we are learning a lot today. So physiotherapy is not about massage. Okay, it's way beyond that. And it's very important in the first 6 months of stroke. Am I right? All right. So let me come to Nancy now. Nancy, you know, everybody knows about, at least would have heard about physiotherapy. But your field, occupational therapy, I don't know whether people even know that it exists. And what is it about?
Thank you so much, Doc. It's true. Majority of our population do not know about occupational therapy. And occupational therapy has also been in existence, okay, let me say has been revived in the last about 7, 8 years. It used to be in the system, but I don't know what happened, and there were no therapists for over 50 years. And so in 2016, we had the first group of locally trained occupational therapists. So occupation itself is what we do in a day. So what you do when you wake up is not just about your paid job. That is just one aspect of it. So when you bath is an occupation. When you eat is an occupation. So everything that you do is occupation. When you come to children, they also have their own set of occupation. We expect children to play, to learn, and to be able to do self-care activities for themselves. So when we say occupational therapy, it is an aspect of healthcare that helps people who, due to one reason or the other, have a temporal or permanent disability or condition to be able to do the things that they want to do. So for a child that has sickle cell and has stroke, then we are expecting that the child will have challenges with ADLs, such as feeding, such as bathing by themselves, such as, yes, eating by themselves. When they go to school, we expect them to be able to learn, but sometimes their cognitive functioning is impaired. So they'll be slow, they'll have writing difficulties, attention, and a whole lot. Then occupational therapists come in to help them. So for us, our ultimate goal is quality of life in adulthood. When they are young, they are playing and they are learning, but they are growing. And we have to ensure that all these things that they are learning in childhood, when they grow up, they have the best of life. We can't say just because they have sickle cell and they have stroke, then it means that we should just let them be. No, they have to be independent in their life. They have to be able to do things for themselves, like I've mentioned earlier. So your OTs come in to help the child to be able to do this. They base on their strength and then they build on them so that our children are not left like that. They are able to have quality life as they are growing.
Great, great, great. So thank you so much, Nancy. I'm glad you mentioned cognitive impairment. Okay. So, you know, when Miss Dinah was giving explanation, she mentioned that some of the strokes can be silent. And some of the silent stroke will just present with decline in cognitive function. So now that we know that occupational therapy is available for such children, can you help us with some of the strategies that you use in helping these children out?
Okay. So like I said, they lose their cognitive impairment. That has to do with, say, memory. So a child is intelligent, they get the stroke, and all of a sudden, they are not able to follow with learning. So your OT comes in, we look at the child. So now what level is the child able to? So we come down to the very basic level of the child. We go back and we take the child. So we have individual plan for the child to be able to learn. So like memory recall, we say, okay, now you don't remember stuff. So how can we help you remember things that you've learned? Then we come in with, say, example, visual cues. But every child is different and every child with stroke is different. So their strategies are different. But for example, we can use something like visual cues to help the child. We put something there and say, you do this, after this, you do this next. These are some of the things, but like I said, every child is different, but your OT will base on the child's strength at their level and plan something for them to be able to overcome the challenge as they are going through.
Thank you so, so much. Thank you so much. So I'll come to Nana. Nana, can you tell us some of the challenges that you face from day to day as you battle with a child having stroke?
Well, the challenges are many. And then start with, I would say, time. You know, with time, like you put your effort and time with everything your child is going through. So you stop with everything you are doing, your work, and then you follow your work to the hospital, going back and forth. That means you're not having enough time to go to work and search for money. And then when it comes to emotional, with myself, I'm the only one doing everything. You know, so I have to be there for my wife because she cannot even take the child to the hospital because she don't have that strength. Not like us, she's sick, but then she's not someone who is that, you know, when you hear your child is sick, she don't have that courage to take her to the hospital because she feel like anytime she goes there, she start crying. So one, I have to be there for her and the kid and the rest of the siblings. So it's really difficult. Time and money. That is what I would say. That is the most challenging part. And then with my child to now, she's not going to school. So it has affected her education. She's at home because I want her to, you know, get better before she starts schooling. So far that is what I'm going to say.
Thank you so, so much. So it can be very challenging financially, emotionally. Okay. Thank you for sharing this with us. So before I come back to you, Nana, Miss Dinah, can every clinician manage children with, say they're able to recognize it? Can every clinician manage a child with stroke? What are some of the management strategies that we use?
All right. So I'm just wondering how many hematologists are in Ghana. Talk about nursing and then clinician hematologists. Very few. And we are all based in the two major cities. So what happens to all the children that are outside Accra and then Kumasi? That will mean that it's not only the hematologists that can take care of them. Everybody. So it's a multidisciplinary approach. So the pediatrician, the speech therapist, famous occupational physio, the neurologist, the psychologist, the social worker, everybody has a part to play when somebody has a stroke, and even the caregiver. So how do we manage them when they have the stroke? So when the child has a stroke, the main idea is to not let the stroke happen. But when the stroke happens, now you need to ensure that the stroke does not happen again. So in the acute phase, what do? The most important thing to do is to transfuse that child. Now, the whole idea here or the goal of this transfusion is not because the child's hemoglobin level is low. You want to reduce the circulating hemoglobin S to at least 30%. How do you achieve that? You can do a simple top-up transfusion where you are aiming at a hemoglobin level of 10, at most 11, when you are so skewed, to increase the circulating hemoglobin A. That's the most important thing you need to do. And then if there are any other issues that has to do, maybe the child is having a seizure, then you want to abort the seizure. If there are any other things, then you want to attend to it. That the most important thing is to transfuse. Now, where does the challenge come? So the child comes to you and has a stroke, and the hemoglobin level is 10 grams per deciliter. That is where you want to aim at. The child already has a very high age. What do? Then you cannot do a simple top-up transfusion. So you have to look at doing what? An exchange blood transfusion. So every clinician's nightmare. So you look at a tiny child, there are no peripheral veins. You're not going to look for somebody who puts in a central line for you. Can the parents afford? Just put in the child. I don't know how much it costs to have the exchange transfusion done at Rage now. But years ago, it was about 5,000 cedis. So if they can't, then what else? So those are the two things. Now, once the child has stroke, the optimum management to prevent the subsequent stroke is the chronic transfusions, which you are doing every 3 to 4 weeks to always keep that circulating hemoglobin to less than 30%. So this is just a planned transfusion, long term. But then what are the problems? Issues with chelation, issues with even getting the blood. So Mr. Dankwa will tell you, it takes 3 days of him waiting for me to give him the green light that I've secured the blood, so come in. And then he comes for the transfusion. What about finances? So even though that is the ideal way to go, sometimes these confounders will not allow you to do it. So what else do? Hydroxyurea. Even though hydroxyurea is not as optimum as doing the chronic transfusions, it's better than not doing anything. If I have a first stroke and you don't do anything about it, I stand more than 70% chance of suffering a second and a third stroke. And in each stroke, the child suffers is losing more functions. So I've had children who have had 5, 6 strokes uncountable. They have residual seizures that are very difficult to control. They've lost a lot of quality of life. They are not home. So this is my little girl that is a phase. She's not going to school. She's home. So you realize that not doing anything is not an option when a child has a stroke. Either you are doing the chronic transfusions or you are putting the child on the hydroxyurea. In this case, then you are looking at what secondary prevention of stroke. So your main aim is to prevent a second or third stroke from happening. So these are the two main ways that we go. Of course, they are palliative in nature, both your chronic transfusion and your hydroxyurea. If you are looking at curative, then you are looking at what? Your bone marrow transplant. Again, it has issues. Graft versus host disease, rejection, cost. And then again, when the child has a vasculopathy, that is where the challenge is. Because the children that have the vasculopathies, you realize that they don't do well on hydroxyurea. So when that happens, then you are really stuck. You are left with only to put the child on what? Chronic transfusions. So when you rate that, then you need to have what? Look at what's the bone marrow transplant, and then gene therapy, which is still in the clinical phase. But the integral part of the management is the multidisciplinary approach. So you as the hematologist or the pediatrician, you are dealing with the stroke not recurring. But what about all the issues that has happened as a result of the stroke? So the early referral to the physio, to the occupational, to the neurologist, to the psychologist, to the speech therapist. So we realize that depending on what are the effects of the stroke, one or either of these professionals will come in. And then lastly, the counseling. The counseling and the support is very, very important. Sure, you heard what Mr. Dankwa said. It is not easy. The impact of a stroke is not just on that child alone. It affects the whole family. Stigma, number one. Number two, finances. Number three, the child's quality of life. So the child is not going to school. So I had a boy that was in class 6, and his class was upstairs. So after the stroke, he has to go back to school. How was he going to go upstairs? So somebody has to carry him every morning to climb up because his class is on the 2nd floor. How does this 11-year-old feels? He walks. He woke up one morning, he went to school, and then suddenly he was playing with the friends, and he fell. And the friends told him to get up, and he couldn't get up, and suddenly he had half of his body was weak. So so the counseling and the support is very important. How do you get the parents to understand what has happened to their child? They play a very big role in the management of the child with a stroke. We can sit as clinicians and write all our nice things, but if he took his child home and never brought the child back, if he understands what has gone in, he knows that the healthcare providers, we are there to support them throughout the journey. Then you are able to get maximum help. Out there, to everybody out there, a stroke in a child is a curse. Yes, it's a spiritual thing right away. Even though sometimes we don't believe, but that is what is out there. Talk to average people that if you see a stroke in a 2-year-old, what will come? And the first thing they will tell you that is spiritual. Forget about the educational background of the person. They will tell you it is spiritual. And we've had a lot of the children being taken to churches, being taken to traditionalists, because we've not been able to get the parents to buy into what has really helped the child to prevent the subsequent strokes.
So thank you, Ms. Dinah. Now we know that there are strategies for managing children with stroke. Sickle cell disease patients who develop stroke. So remember that immediately you have to transfuse them, and then you have a target HB of 10 to 11 grams per deciliter. But it doesn't end there. You are going to be doing chronic transfusions, and it's important that you let pediatrician or a pediatric, preferably pediatric hematologist, have a look at that child. So as Ms. Dinah was talking, she made mention of the environment, the classroom. So now I come back to Ms. Nancy. So how do we adapt the environment to meet the needs of children who develop?
Right. So right away, we start with environmental adaptations that includes ramps. So if they are going to be wheelchair bound, then our school settings should have ramps in place, okay, so that the children can move about in the school environment. For others that can afford elevator, which is too much to ask for top floors, and that they can also look at it for schools. Then also for the basics, we can have the hand grabs on the wall, because we are looking at mobility challenges. If there are the hand grabs on the wall and they can move about themselves, we are championing independence. They're able to move by themselves. They don't have to rely on anybody to navigate the school environment. Then it goes on and on and on to also look at what they are even accessing in the school environment. How is their seating like when they are out of the wheelchair? What are they sitting in? The school itself, the curriculum, what are they learning in there? So we also have to look at the IEPs that we have for them. These are also environment in other contexts. So we want our children with stroke to be able to access the best of education in the school environment. So it boils down on all of us, everyone, head teacher to parents, to colleagues in the school. We should try to make the place as mobile as possible for them. And the basic we can ask for is a wheelchair accessibility, and then But of course, from my angle, we also come in to modify things. So for a child that is not able to write, we come in, occupational therapists, we come in to say, okay, why don't we increase the surface area of the writing pen? If it is small, then they're using so much energy, so much force to calibrate it. So why don't we increase the size for the child? We are looking at using marker board or surfaces that are easy to write on so that they don't spend so much energy and time writing. Already they are struggling, they are fatigued, they fatigue easily, they use so much energy to do the bare minimum. So we come in to try and see how best we can do it. We know that when you are writing and you write plain, like lying down, then the child is using more energy, but then your OT will recommend that you do it vertical position. When you're doing it vertically, the child is not using so much energy because it is against gravity. So these are some of the things that your OTs add on in the school environment to help, them to be able to function at their best. Yes.
Thank you so much, Ms. Dinah. So you can actually put your questions on the Q&A box. We'll be dealing with questions very soon. We'll be rounding up very soon with the panel discussions. So let me come to Nana. So the challenges that she just talked about, have you had to face them with your child?
Well, with my child, she has not started school yet. It's just us in the house, and then we come to the hospital. So far, I've not faced any challenges. She just play around with her siblings, and then we, the parent, will make sure we support her in everything. So far, we are not facing any challenges. Hopefully, next time she'll go to school. So, and then the school, they are aware. So I think they will provide the necessary support for her.
Indeed, indeed. The management of sickle cell disease with stroke is multidisciplinary. And, sometimes what this means is that we even need governmental and non-governmental agencies coming in, because if we have to provide RAMs, so anytime somebody is building their school or the government is building a school, remember that these things can happen, even though we don't want them to happen. So we're talking about prevention very soon. We don't want any child to get stroke. But before then, let me speak with Jemima. So if a child who is in school has to be doing physiotherapy, how do you integrate this into their daily routines so that they don't have to miss several school days?
Thank you very much. So it depends on how the stroke affected the client. So usually if it's an hemiplegic stroke, for instance, and then there's total paralysis, in the acute stages, it's not, for me as a physiotherapist, it would be best to start the rehab, do a lot of strengthening exercises, before, when we achieve some level of function, then they go back to the school. So usually we talk to the parents. Education is very important. When they get to understand that this is what your child is presenting with, the issues, they have the complaints, they can't sit by themselves, they can't transfer by themselves. And then we let them know that this is what we are coming to do. We teach them transfers, we teach them exercises, including home exercise programs, and then they do them. When they achieve a certain level of function and they begin school, let's say now the patient is walking, but the gait is still not as to how the person was before the stroke happened, they can start school. Usually we write excuse letters for the school. Sometimes we send it via emails so that they would also know that this patient is coming for physiotherapy, and then we give them the school that this time the patient will be coming for physiotherapy at this time. So they are aware that this child has this condition, will be coming for physiotherapy at this time, so that they can allow them to leave the school and then come for the physio. Some schools are very understanding, so sometimes they will consider them if even there is a quiz or there's a certain class that is very essential, they will know that, oh, this student is going for physio at this time. So they'll be giving maybe permission to maybe redo a quiz or something like that. So usually we write excuse letters, send it via emails, and then the school is aware of what is happening to the patient.
It's
Thank you.
really, really good to know. I mean, we're all happy that there are some of these advances taking place, and no parent should give excuses that physiotherapy will make their children not go to school and all sorts of those excuses. So for now, I want to talk about the prevention of stroke. I go back to Ms. Dinah. Can stroke in sickle cell disease patients be prevented?
Yes, so I think the most and the goal of all healthcare professionals who are involved in care of persons with sickle cell is to prevent the stroke from happening in the first. If you remember, when we looked at the incidents, we said if we don't put any risk screening measures in place or preventive measures, 11% of these patients will likely stroke. Now, how do you prevent it? So the person has sickle cell disease. The disease itself puts the person at risk of developing the stroke. So a simple screening scan called the transcranial Doppler ultrasound, TCD. It's a validated scan that has proved to be able to pick the risk of stroke. Now, remember that we said it's the big arteries that also contribute to the strokes. So a simple TCD, in fact, you can pack a transcranial Doppler machine into a bag and hold. The cost of a transcranial Doppler, sometimes I don't want to say things, but a V8 can buy maybe 10 or 12 of a transcranial Doppler ultrasound machine. Just doing that scan from age 2 for the patients who have phenotypes HBSS and S-beta thal 0 at age 2. The child in your clinic should not just be coming in for folic acid, Zincovit, and go home. Make sure that child has a scan, because 1 in 10 children who have sickle cell disease is at risk of having a stroke. How do you determine who will have the stroke? Is it by their beauty or how rich the parents are? It's by doing the scan for them. And then when you do the transcranial Doppler ultrasound, you're measuring the velocities of the blood flow through the cerebral vessels. And 2 big vessels, the middle cerebral arteries and internal carotid arteries, are 2 big vessels that are predictive of risk of stroke. So if you are seeing the child and you don't have access to the transcranial Doppler, make sure that the child has that. And from age 2, if the transcranial Dopplers are normal, you do it annually till the child is 16. After 16, the validated one that we have is no more predictive. But the first 16 years, it's important that the child has the annual transcranial Doppler ultrasound done. That is a screening scan. And that is one way that has reduced the risk of stroke, because when you identify the child to be at risk of developing the stroke, you will put in the measures, which is the primary prevention of stroke. So it's either you are giving the child transfusions to prevent the stroke from happening, where you are giving the chronic transfusion, or you initiate hydroxyurea. And that is why we are also saying that don't wait for overt problems to come before you start hydroxyurea. Put the child on hydroxyurea from 9 months of age. It is safe to put the child who has HBSS or S-beta thal 0 on hydroxyurea. And once you do that, that is also one way of reducing the risk of that child having a stroke. Now, you don't have a TCD machine. In Accra here, there's one place that does the TCDs, and it's even somebody's private hospital. So I'm wondering, the clinician who is in Sunyani, who is in Swedru, is asking, so where do I send a patient in my clinic to? And that is a very real question that people are asking. So as we are talking about stroke, we are also advocating that this simple machine be made available. In parts of the world, it is part of routine care. So as the child goes to clinic, nurses in Kolebu, we've been trained to do the TCD. I know how to do it. 2 other nurses know. But that machine is from somebody's clinical trial. And that's why we have that machine there. But every other person here is doing it on private basis to be able to get that scan done. And I'm telling you that the parents whose children have had strokes, they will give everything to even save the child by saving money to do that scan, to be able to identify that their child was what? At risk of developing a stroke. So let's prevent. The prevention is what? Key. Talk to people, try and refer the child, even if it is once every 3 years, for them to be able to assess and get the TCD done. Get it done. Get somebody who is well-versed in it to help you interpret it, because if you have the results and you are not able to interpret it, then you can't make sense of it. So let's get it done. Get somebody to interpret it for you and then help you to be able to do it. If you have a child with stroke that you are managing, talk to other people. These 2 children from the Volta region, it was actually a 2nd-year house officer that picked the 2nd sibling of the child because of his experience in the teaching hospital. That he was able to pick the 2nd child who had the stroke and refer. Talk to people when you have the problem. Sometimes we can help you manage the child there. And then later on, the child can come to see the hematologist or a well-established sickle cell clinic where they can get access to the transcranial Doppler, the hydroxy area, and other things.
Thank you so much. So now we know that stroke can be prevented in children living with sickle cell disease, and we should all aim to prevent this. Nana, I'm coming back to you. What have been your coping strategies so far? Coping strategies.
So far, I've been following what Dr. Diana has been helping me with. She has been so helpful with her advice and then how to cope with my child. Well, I'm hoping she'll get better. But then it's all about money. If I have enough money, maybe we do the bone marrow. That is it. If it's not that, we are still on transfusion every month to see how God will do, because there's still a miracle. I believe in miracle. Maybe God will work a miracle out. So that is a hope I have for now. But if I have some money, I'll go for the bone marrow. If not, maybe God should just work a miracle, because it's part of it. Because just like Dr. Diana said, people believe it's a spiritual disease. You know, the moment you discuss with someone, so this one it's a spiritual, we have to pray. So we'll pray and then hope maybe God will open a way, then we can go for the bone marrow.
But do you believe it's spiritual?
This is Africa. So
It's Africa indeed.
yeah,
This is Africa.
and anything is possible.
Anything is
Because I once heard Nancy, that musician. She said he said here he was a sickle cell, and then every morning he took his drugs, and then one day he just prayed and then said that God should heal him, and then
He was
since
healed.
then. So if this prophecy is out there or anything like that, I also believe that one day maybe
A
my
child
time will
will be
come and then he
healed.
will be here. So
Amen.
that is it.
Amen. Okay, so we are grateful to all of you for your input so far. Our time is really running fast, and we are now going into the questions Q&A session. So you can decide to raise your hand. We'll unmute you and you speak. You can also put your questions in the Q&A box, and then it will be answered for you. So there are a few questions in-house, online, and then
So I think the first question is, can a child with sickle cell be placed on anticoagulant therapy to prevent the occurrence of stroke? So I think anticoagulants, like they mean maybe blood thinners to prevent stroke.
Okay. this week. So you realize that the nature of the stroke in children is a bit different from the adults. Is that okay? So putting them on the blood thinners is not going to prevent it. For those with the sickle cell, we actually know the pathophysiology. We know what is actually happening. That is because of the sickle nature and the damage to the inner aspect. So routinely putting them on blood thinners is not something that we routinely do. But sometimes with the children who have their vasculopathies, so sometimes when they have their vasculopathy, then sometimes we put them on low dose. Okay, so sometimes the child may have a stroke, okay? But then the vessels itself or the tubes that carry the blood in the brain may also be damaged itself. So some things like moya, where you have the vessels, from like a rope, they are intertwining. Then with those ones, there's a problem with the vessel itself. There's a damage. Sometimes the whole vessel is occluded. With those children, you may want to put them on low dose aspirin to deal with that because of the vasculopathy. But normally, in the absence of that, we manage them on the chronic transfusions and the hydroxyurea.
Okay, so we understand that prevention of stroke is not with anticoagulants. So that's the baseline. Okay.
What is the earliest age a clinician can identify sickle cell disease in children?
Oh. So averagely or commonly by 6 months, because you tend to start losing your hemoglobin F, which is the protective hemoglobin. It doesn't stay. By age 1, you have less than 1%. But averagely is from 6 months. But I've seen children as early as 4 months. I have an experience where the child had their first splenic sequestration at 4 months. At 4 months, the child's HB was 4. Yes. So even though averagely and commonly is from 6 months, start looking out for it early. From 4 months, it can happen.
But we also know that newborn screening is in place, and it's actually very important to have. You can have when you do it at birth, you may not have a conclusive genotype, but you can have the suspicion that this person is likely to be sickle cell, and then you start treatments and follow up very early, and then at 6 months you confirm.
The next question is a very interesting one. Is the Pediatric Society considering having a written consensus with traditional leaders, Christian leaders, and Muslim leaders to make it mandatory for all couples who want to get married to compulsorily do HB electrophoresis, which will go a long way to reduce the incidence of sickle cell disease? I think that as Pediatric Society of Ghana, we would usually discuss with key people in the field to decide on certain things. We as PSG cannot enforce a rule like this. And so if clinicians and the other parties think at some point that is mandatory for such an exercise to be done, I'm sure those who are in charge of policies and things would, but until then, I don't think as PSG, we can enforce this. We can only encourage people to know their status. So we always say, know your status. Know if you are AS or SS or SC. If you feel after knowing you are SS, you can still marry a partner who also carries the gene, then at least you are aware of what you are up against. The important thing is to know your status. So as PSG, I think this is our stance. I don't know if any of the other executives have a response to this.
So maybe if a president or other executives would want to speak, you could alert us to unmute you. But I think mainly PSG is doing very well with advocacy. This is exactly what's one of the things we are doing to let you know that it exists. But we actually cannot force you that don't marry or marry. So that would be a personal decision to take.
So the next question, is there any help with provision of test kits for screening babies at the peripheral facilities? If yes, how do we get it? I think you mentioned something about that.
Okay. So that is also the biggest problem that we are facing. If you have 2% of your annual births having sickle cell disease, 15,000 babies born in your country every year with sickle cell disease, and you don't do newborn screening, I don't know what else we want to do. So newborn screening since 1996 has been on sponsorship. Currently, there are only 4 sites screening in the whole of Ghana: Kolebu, Osha Polyclinic, under private sponsorship, 37 and Ridge under private sponsorship. There is no nationwide coverage for sickle cell disease. There are some bedside devices that have come into play now, where it's a very small device, where even the remote side, you will be able to pick the newborn for sickle cell. So we are advocating for Ghana Health Service to buy it and keep it there so the children can get diagnosed. But nationwide newborn screening, no, it's not available. And these sites I've mentioned is for free. If you find yourself there, the baby will be screened for free.
Thank you so much.
A 4-year child was brought in by their parents with complaints of frequently sleeping in class, which was affecting the child's academic performance. The child, however, doesn't sleep frequently in the house. Unfortunately, I didn't screen for sickle cell. Is there the need to?
So several things may let that child become sleepy, even though we know that patients with sickle cell, they easily get tired and may sleep. But with this, I think that in our part of any child that comes to you with any fever, I think a lot of facilities do it. Once you come in with a fever or low hemoglobin, one of the tests we'll do is HB electrophoresis. But I cannot foresee that with just one presentation to say that this child could have sickle cell. But there's no harm in screening them. But take a history and find out whether there are other signs like bone pain, there's been jaundice and all those things before. By just looking at this one presentation, it will be difficult.
Okay, so if you have the opportunity to see that child again, please do it. It doesn't hurt. Okay, let the child know their status. But it may be beyond sickle cell disease as well, because there are other conditions we haven't spoken about. So you can refer to a pediatrician for assessments.
My son is sickle cell disease and has been taking only folic acid, blood tonic, and penicillin V. Is it good?
So this is where we come in, that now medication like hydroxyurea therapy has been included in the treatment guidelines for sickle cell disease in Ghana. Now it is part of routine care. So the era of just putting them on micronutrients, so especially for those who have the phenotypes HBSS and the S beta thal0. Let's talk. A few months ago, I had a sibling referred to me. The child runs HBs of 6, has been off hydroxyurea for a year. And then I said, okay, let's screen the others. The other 2 siblings who also have sickle cell disease, they don't go to any clinic. So once a while, then the mother will give the child folic acid and zinc. And then these 2 were also diagnosed, also running the same HBs of 6.4. So to the mom, oh, they are fine. I'm giving folic acid and zinc. So this is to parents. This is to clinicians. Don't assume that, oh, this child doesn't get any bone pain. Oh, this child is fine. So the folic acid and zinc is okay. No. Talk to the parents, offer hydroxyurea, because the fact that they are not having bone pain, there's a lot of organ damage that is going on in that child. By the time the child is a young adult, you see all the nephropathies, their retinopathies and all that. So we are moving away from the era of just keeping the child on on folic acid and the multivitamins.
But let me give a caution here. You know, hydroxyurea cannot be prescribed by anybody. It has to be pediatrician, well versed in the area, preferably a pediatric nurse specialist, heme specialist, or a hematologist. That's the ideal thing. So once this is coming from a parent, what I would say is that you could, it actually would depend on the age of this child. We cannot suggest treatment now because you need to know a lot of things before you can say, okay, go and take this or that. So the age and the genotype, okay, basically, I mean, these are very important in deciding what to give. So for now, what you can do is we don't know where you are, try and find yourself in either Ridge, 37, Kolebu. What are the other centers in Accra where they will be able to access hydroxyurea? They will assess your child. And if your child is eligible for that, then we will start it for the child. So the blood tonic bits, we wouldn't want children with sickle cell disease to be on iron. Okay, so I don't know what that blood tonic contains, so you can hold on with that for now. Continue with the folic acid. The penicillin V will also depend on the age of the child. That's why I'm saying that it's important that you let either a pediatrician assess the child and then we take it from there.
For sickle cell SC, do they have to be on hydroxyurea routinely? I think you mentioned it a bit.
Yes.
So, so for HBSS and S-beta thal 0, you routinely offer to them. But for SC and S-beta thal plus, it's case by case because generally they tend to be fine. But if you get it, sometimes you may get an SC who has severe phenotype. So if the child is coming down with priapism, cerebral acute chest syndrome, then you want to put the child on. Currently, we are doing a clinical trial in Kolebu where we've put 100 children and 100 adults on standard doses of hydroxyurea because a lot of the information we have was used in patients with severe disease, the SS and the S-beta thal 0s. So now after our 3 to 4 year follow-up of these patients, would we be able to come out to issue a blanket statement as in the case of the HBSS and S-beta thal 0 that yes, you can offer it also routinely to patients who have SC. So some SCs are on hydroxyurea for specific reasons, yes.
Hello, please. Do you think there'll be a time where children would sue their parents for their state? How can this be done to protect? How can we protect parents if such a time comes? Then maybe the father.
Do we have a lawyer here?
Well, I'm not sure because this is not something every parent wants. This is the work of God. So if you have any I think you have to see God.
But Nana, you needed to make a choice, okay? A very difficult one. Did you know about it before now?
Well, I didn't check, but you know, they say
You didn't
sometimes
check.
love is blind. You know, sometimes when someone is in love, it's not whatever you say. You know, this is it. You know, sometimes when two young people are in love, you know, they just make decisions. They
Break
don't think
them.
of the future. You know, that is it. So
Yeah, but I
the
think
thing
the
is,
checking
education has
bit-
to be more.
Yeah.
That is the
Yeah.
most important thing.
Yeah.
Because I will not advise anyone that you should go and marry someone who is AS and you are AS, you know, because of what I've experienced. So I think it's more of education, you know, that is the most important thing. Because sometimes it's not about it's about the love, you know, that is how most people do it. Yeah. So
Okay, so there are actually options, you know, but it comes to finances. So if you are AS, somebody else is AS, you can decide to marry. And then when you conceive, they can actually screen the child for sickle cell as early, say in the first 12 weeks. And then if the child is AA, you carry the pregnancy. But all this boils down to money and availability of resources in our part of the country.
So are you encouraging it or what?
So,
You will-
so I'm telling people that
So that's what I'm saying. It should be more of education. Well, it doesn't comes with money or like finance or whatever it is.
if you have the money, you can actually do that. But if you don't have the money, then you don't do that. So if you have the money and you love yourselves very well, you can go for that option.
Yeah.
Okay.
But how would a young kid be having money at that stage to take care of? Yeah, so it's not an option.
Okay.
Say you are 20, you want to get married, and you are now starting life, and then you are thinking about getting a child who is ill before so it's not advisable. That's all.
Well,
As clinicians in the district and sub-districts, how can we secure hydroxyurea for our patients in these low resource areas? Is there any program for this? I think the chairperson, he will respond.
Yeah, thank you very much. Can you hear me?
Yes, please, we can hear you.
So absolutely, you can get hydroxyurea for your patients in the districts and sub-districts. Hydroxyurea is under the benefit package of the National Health Insurance Authority. So in Konfanochi Teaching Hospital, patients get hydroxyurea on NHIS for free. Now, let's get this clear. Hydroxyurea is absolutely safe. You don't need a professor, a hematologist, or something to be able to manage a patient on hydroxyurea therapy. Like Diana said, every sickle cell patient, SS or the severe type, you must be on hydroxyurea first, folic acid, penicillin V. Those are our standard medications. Many thanks to the Ghana government and through the efforts of may he rest in peace, Kwaku Hinefrempong, and Novartis, we now have access to hydroxyurea on NHIS. However, many prescribers are under the wrong impression that they must be either a specialist hematologist or it has to be in a teaching hospital before they can do it. The NHIS has clear guidance, and I have guided smaller facilities. I'm not using smaller derogatory. I mean facilities that are district level to be able to do it. And now there's one facility that has written to NHIS and saying, Dr. Setitu is supervising us. We have about 50 patients coming to our clinic. Can you help us with hydroxyurea access? All your facility needs to do is to go to NHIS and say, I have either a pediatrician, an internal medicine specialist, or if you are lucky to have a hematologist or family medicine specialist or somebody who comes there to help me manage these patients. And then you must have some basic laboratory tests. All you need is a full blood count machine, and every district hospital has a full blood count machine. And maybe an ability to tell baseline what the renal function and kidney functions are. And again, if you treat pregnant women, if you do surgeries, you have all these things available to you already. And then you may have to get somebody to sort of walk you through the Ghana standard treatment guidelines and say, this is how to safely do it. In Ghana, you guys in that room, 25% of you, every fourth person probably carries the abnormal sickle cell gene. There are children dying before the age of 5 years, as many as 90% before they are even diagnosed. We are treating sickle cell disease with kid gloves and expecting all patients to move from Tumu and whatever to either Accra or those who are lucky or to Kumasi to come and get hydroxyurea therapy. It's not going to work. We don't have the resources to salvage them when the disease becomes so severe. We need, as clinicians, as prescribers, to move in and actively fight for these patients. So I see people saying, oh, come to Konfanochi, come to Konfanochi. They are traveling hours to spend hours in queue for a simple medication that they can swallow in their homes. Why do you have to travel to Kolebu to come and get hydroxyurea? So if you have a district with internal medicine physician, family medicine physician, pediatrician, not a pediatric hematologist, and if you are lucky to have access to a hematologist, you are qualified to go to NHIA and say, can you come and look at my facility, whether I can do hydroxyurea therapy? There are many district hospitals doing it. Agogo is doing it. Several hospitals are doing it. So we need to take it seriously and demystify this thing about it has to be prescribed by some big man sitting in Accra or Kumasi. There are so many children and adults out there who have not seen this medication since 1980s that we know is completely safe. Okay, so all over, at least from this, I'm happy this question came. The thing that we know that's the lowest hanging fruit that we can use currently are one, ensuring that we diagnose these babies early. And again, it's the same argument. There are people, there are parents who can afford to pay for early diagnosis or newborn screening. Why are hospitals not even offering them as part of services they can pay? These patients pay for MRIs. They pay for all these expensive, sometimes tests that we don't even need. They pay for them. Yet we do not have newborn screening as part of the services that we offer. First, you offer it in the facility and then worry about whether the parent can pay for it or not, because there are people who can pay for it. So why are we not offering it? So it's the same argument. So in a country where you have so many sickle cell patients, we seem not to be interested to deal with the disease. Okay, so you don't need any special, just walk to NHIS, say, I have this personnel, and it's all about leadership. The leaders must lead, okay? And that's the level of advocacy at the healthcare delivery point or NHIS.
All right, thank you very much. So I think our chairperson has answered a lot of the questions in the chat box directly or indirectly. What are the protocols before the initiation of hydroxyurea and at what dosage?
Okay, so basically, your liver function test, your renal function test is basic, is very important because your liver will metabolize the hydroxyurea and your kidneys will excrete it. And that is why it's important that you go in and have this. People want to add viral screens. It's nice to do, but don't say that because the patient couldn't do hepatitis B or C or retro, I'm not putting the person on on hydroxyurea. That is not going to prevent you. So what about if the patient is retro positive? I have patients who are retro positive who are on hydroxyurea. So your basic LFTs and your BUE, and then your full blood count with your reticulocyte basic minimum, it's okay for you to move. Just recently, I was talking to one of the renowned pediatric hematologists. He works in Canada. And he was like, so if you have a child that needs hydroxyurea, but they are not able to do the baseline labs, what do you do? I just sitting there. I just looked at him and I said, just those 3 labs, the patient will need almost 500 cedis to have that lab test. And then he said, Diana, I'll put that child on hydroxyurea and think about the baseline labs later. So sometimes you find yourself so tight, even though we need these baseline labs. That is what the protocol says. But this is somebody who practices in Canada. But what is the reality? He's a Ghanaian, but he practices in Canada. But these are the realities on the ground. Do you leave that child to go? And the next time you see the child in the emergency room with a stroke or even dead. So that is another question for us to answer. So these are the basic baseline labs you need to start. And then the start dose, me and pediatric bias, 18 to 20 milligram per kg. That's what the adults may start anything 10 to 15. But for the children, anything 18 to 20 milligram per kg as a start dose. It's okay. It's the start dose.
Okay. So we have one more question, and after that, we'll have the closing remarks.
In case a child is allergic to hydroxyurea, what can be used instead?
I won't say allergic. Some people don't tolerate it. Okay. So that's also the more reason if you heard Dr. Oti was saying you need a basic full blood count in your hospital. Now, because hydroxyurea is myelosuppressive, that's why when you start and the patient is on, you need to make sure you are checking your neutrophils, your platelets to make sure they are within safe limits. So there are few people, lucky for us here in Ghana, I don't know for other treatment centers, but in Kolebu Pediatrics, we have more than 2,500 children who are on hydroxyurea in our clinic. We've been very lucky. We have more than 95% responding, or even 98% responding. A few of them don't respond. Worldwide, people are reporting 30 to 40% of people not responding. But we have a very good response. So if the child is having toxicities over and over, sometimes we stop. A few of the children that I had to stop their hydroxyurea, after some time, we put them back on. Sometimes we titrate the dose down. And that's why it's important that when you are following a child on hydro, you should have some experience or have somebody who is experienced in it who will be helping you deal with these toxicities. There are some people who just don't tolerate it at all. Then we may have to look at, for instance, if the child has a stroke, then you may have to put the child on chronic transfusions for or there are newer drugs in town, L-glutamine, even though it's a very cumbersome medication to administer and it's very expensive. I don't know if any people are stocking it. There's Ozibita and then crizanlizumab, but all these are in clinical phases as we talk. So you may need to look at a few things if the child is not tolerating.
Thank you so much, everyone, for your inputs. At this point, we would like to take a video from Novartis. Yes. Our proud sponsors. Thank you so much, Novartis.
It's not merely the absence of disease, but a sense of physical, social, and mental well-being.
Equitable access to health means health for everyone.
The outcome of a disease is being only determined by the disease itself.
Those who are more disadvantaged need to get more to pull them up. I think it's one of the most unfair things that one can ever go through, where I'm born with a genetic disorder, I deserve to die. All my life, I always wanted 2 kids. And I told myself I'll get 2 children, regardless of whether they are male, female, I didn't care. When my son was born, he presented some symptoms which were not making sense. He was jaundiced and he was also very weak. So we took him to hospital and the doctors also realized that he was anemic. At that point is when one doctor came in and she asked for sickle cell test. And that was the beginning of the journey.
We have challenges because if you look at the number of babies that are born with sickle cell across the world, you have more than 70% of them being in the sub-Saharan Africa, and this is a great burden to us. When you were given that diagnosis, what were you thinking?
Death. I was scared. I remember holding my son in my hands and I started crying. Most of the time, the conversations would be somebody living with sickle cell anemia would never live to see a certain age. And that was what hit me first.
In a sense, that the inequity that has affected people with sickle cell disease is an example of the broader inequity that affects people who do not have the resources or who are unfortunate to live in places where resources are strained.
Really, the challenging sub-Saharan Africa is that the health systems are weak and there is no coherent plan to strengthen the health system in a coordinated manner.
I think for many years in global health, we have brought solutions into countries without developing a framework in which they could flourish. When we were looking at countries where we could make a first start, Ghana came to mind for a number of reasons. There was a good environment and a willingness, a political will to make a difference.
Working with the Sickle Cell Foundation of Ghana in collaboration with the Ministry of Health, Novartis put together a public-private partnership to address sickle cell disease holistically.
The ambition was the government of Ghana would come to the realization of the burden of sickle cell disease in the country, be able to prioritize that, and be able to ensure at the end of the project's life that the hydroxyurea would be taken on as a reimbursable drug.
We were also working with, for instance, local universities to develop treatment guidelines. We were putting in place a monitoring and evaluation framework.
Which kind of personnel do you have to have? What kind of laboratory resources should you have? What kind of clinical intervention should you be able to deliver? It is all part of the whole health system strengthening strategy.
When we signed the Memorandum of Understanding, our hope was to see improvement in the quality of lives of sicklers, improvement in capacity building.
The ambition of our program is to provide access to comprehensive management of sickle cell disease for patients who need it, where the burden of disease is.
In order to bring other stakeholders along, we made some catalytic investments, but we also actively lobbied, for instance, other private sector players to join the program on the diagnostic front, on the data management front, in order to make a bigger impact.
In sub-Saharan Africa, PerkinElmer's aim is to support and increase capacity for sickle cell newborn screening. I think what has brought us together is that we share the same common goal, and we can improve the advocacy effort in sub-Saharan Africa.
We realized that Novartis was operating in several of the countries where CONSA is operating. And so that offered a very natural opportunity for collaboration to reach all these people who sometimes live remotely from major urban centers. It requires a lot of resources. And so Novartis has been helpful with accessing the required resources and also provide the materials that are required to educate the healthcare providers.
When my kid got sickle cell anemia and was diagnosed of it, it left me curious, wondering what's this disease? How does it present? What is it that we did wrong? So as I walked into Children's Sickle Cell Foundation, that was the beginning of learning of everything about sickle cell and where the gaps are. One of the things I couldn't believe was meeting other people living with sickle cell. Through that, I got interest in learning more about sickle cell disease. And over time, I then ended up becoming a sickle cell advocate.
So this whole concept was actually a co-creation idea. It was a collaboration between Novartis and those of us at Sickle and the Navrongo Health Research Center. It was a real collaborative effort to create a program that will address the core issues that we wanted to address, that is integration into primary care.
Local research is extremely important because people believe in their own people.
When you think about the number of patients who've been identified in the study, I think that really highlights the power of partnership. The health system that you have in the local area is now being strengthened through this partnership. Thank you.
Now I'm doing well. My son is stable. But then every time I meet somebody with sickle cell, they are in tears. Somebody is in so much pain. I'm thinking to myself, how can we help? The partnership with Baraka started because we wanted to just simply change the lives of people living with sickle cell. It was as simple as that. But our role is very clear. Baraka is doing the clinical care. Children's Sickle Cell Foundation is doing the social part of it.
We must ensure that we focus on the entire patient's social, psychological, physical, and spiritual well-being.
As we are working with Baraka in partnership, we are also happy that there are organizations that are coming to us like Novartis, who are calling on to us like, where can we help? Baraka has come in to give people their dignity back. And whenever I look at it, I keep on saying, this is where you get your dignity.
I believe that the time has come for us to see sickle cell disease as something that requires multiple stakeholder collaboration and partnership.
The strength in partnerships is that you are working together for a common cause and a common goal.
Anytime we work on strengthening the response to a disease, we are indeed strengthening the whole healthcare system. We will indeed create resources and create expertise that can then be allocated to other diseases as well.
We have seen tremendous scientific progress in medicines that can cure, attenuate, modify diseases. But in order to bring this benefit to all patients, we need to make sure that the health systems can maximize that inherent benefit of those innovations.
It is only through such an effort that we can vastly change the landscape of sickle cell disease.
No man can live in an island. And that's what we realized with the management of sickle cells. As the gap comes up, who then do you call upon to fill the gap? I think it's about holding hands. And if we hold hands, the circle is bigger and we're able to achieve more.
So I'd like to say thank you so much to Novartis, our proud sponsors, for making this possible, and to Pediatric Society of Ghana, the leading child advocacy. So we're almost at the end of the program. And before we take the chairperson's remarks, I'd like to go back to my panelists and give them the opportunity to tell us their final words, just in 30 seconds each.
Well, I would say any parents with a child that is having a sickle cell, the most important thing is you love the person no matter what. You shouldn't be picky within them, because, you know, when you love them, they also have the confidence to do whatever they want to do. But if you are being picky within them, they always not get the courage to do whatever they want to do. So always love them and cherish them just like you do with the rest of their siblings, and love them like the way you want your parent to love you.
So as healthcare providers, we should work together wherever you find yourself. Reach out, there's help. We've all gone through training. We have mentors, we have consultants. Reach out to them when you are stuck, and they are ready to help you, so that we will ease the pain and burden of our patients traveling all around the country to seek help. There's a sickle cell child next to you in your community. How can you help that child as a healthcare provider?
Right. So your child that has sickle cell has a lot of potential that we've not tapped into it. Your occupational therapist is here to help you. So reach out to us, and together we'll maximize that potential. Thank you.
Thank you. So as a physiotherapist, when you have a child with sickle cell and has had a stroke, it's very important that you start your physiotherapy right on time and then engage in every home exercise program your therapist will give you so that we can achieve your highest maximum function as much as possible. Thank you.
Thank you so much for your time this evening. So we have an evaluation form in the comment section. Kindly log on and then fill it for us. And finally, would like to take our chairperson's remarks, and then we'll have a closing prayer.
Right.
Dr. Oti, okay.
Thank you so very much. It's been an educative session. I thoroughly enjoyed it. And it's great to have an MDT with a parent as part of it. And that's what we don't do well as clinicians in Ghana. Yes, I love the fact that our parents, our clients, our patients, respect us and actually believe that we are gods with a small g. But the best physician is the family. The best physician is the patient. So you need, whatever decision you take, it's about that family. It's about that child. Okay, so I hope we go back thinking and reflecting deeply on what the parent has taught us and what our other colleagues in the MDT. We have all these specialists in the same hospital, yet even coordinating the care for these children, it's heartbreaking. I have seen parents carrying 30-kilo 14-year-olds, 70-kilo 15-year-olds, and walking up a slope to go to physiotherapy. How much physiotherapy will the parent need after that? And yet we are the leaders in the hospital. So there's a lot of responsibility on us. And I feel strongly about the fact that I feel as specialists or as clinicians, we are probably letting our own country down because we are not fighting hard enough. There's access to hydroxyurea and that people don't even want to go ask for it because they just want to refer the patient to the next tertiary hospital. And that is why the government will never know how serious the problem of sickle cell is, because we don't present the challenge as it is. And I felt so sad talking to one of my own colleagues who felt that the data, which is the Global Burden of Disease Study, which says that almost 75% of the 500,000 newly diagnosed babies will be in LMIC countries. She doubted it because she sits in a hospital and she thinks that the whole thing about sickle cell is just about the 10% of kids who are able to make it to her facility. So for her, that is not true. So that tells you how even as advocates, we are not sending out the message properly. So I just hope that, we are talking about stroke, but we sort of hammer on our ability. We have a lot of resources in Ghana so that we harness them more efficiently to make bigger impacts. So many thanks for helping us understand a little bit more about the complexities of this disease that I feel we have wrongly tagged benign. It has very catastrophic and malignant effects on families, on the sufferers, that I guess the benign connotation of it, does not do justice to sickle cell disease. Thank you very much.
So much, Dr. Oti, for agreeing to do this with us. And thank you to everyone for joining us. Thank you for staying by us for the past almost 2 hours. Let's all go and be advocates for sickle cell disease and all other childhood illnesses. So at this point, I would like to call upon Mame to give us the closing prayer.
Shall we pray? Our Father in heaven, we are grateful unto you for such an enlightening session. We pray that, oh God, even as we have learned, your God will make us advocates. Father, help us, grant us grace and the necessary strength to be able to send out the message to everyone out there that the knowledge will reach the ends of the world and we will live even for you. We thank you for our facilitators. We thank you for our organizers, the sponsors, everybody who took part in this education. We pray the Lord, you will help and even bless us in every way possible, that we will do what you have called us even to do. We ask for journey mercies to our various destinations, and we pray the Lord, you be with us and lead us in all we do. Be exalted in our lives. In Jesus' name we pray with thanksgiving. Amen.
Amen. Thank you so much. Kindly fill the evaluation forms for us. Don't forget to do that. Until we organize another session. We want to say thank you again to Novartis and then Pediatric Society of Ghana for making this possible. Until we meet again another time. It is bye from the house. Thank you.